Oh, I see it. Thanks, Monica. Has any issues with sound or something goes awry, just put up your hand or put it in the chat and I'll try to keep an eye out for it, or Monica or someone will on my team will flag it for me. So just wanted to let folks know, hopefully we don't have any technology issues. I'm going to go ahead and share my screen and it will open it up for questions at the end too. So just so folks know. Let's see if I can find it. I think this is the right one. All right, I hope everyone can see that. Let me get situated for just a second. All right. Okay. There we go. So, okay, let's just dive in. So real quick, this is the second one, like I mentioned, a presentation we're doing around some of the work we're doing for children's behavioral health. We're calling it the Children's Behavioral Health Transformation Project. CBHT has become sort of an internal acronym. So if you see that, that's what that means. But before we dive in on some of the issues, I wanted to do a quick snapshot of some of the children, how many children we think potentially may qualify. We are also in the future going to be looking at children at risk of serious emotional disorder. Many of you on the call and some feedback we got from the last workshop was really helpful in realizing that we want to see if we can try to get some of these services up front and earlier, more upstream in the process. So not only catching children when they have a serious emotional disorder designation, but trying to find a way to catch children who might be at risk of that, or families that might be at risk of placing their child in a residential treatment center or inpatient. All right, so just a real quick reminder, back in October of 2022, the U.S. Department of Justice found Nevada out of compliance with the Americans with Disabilities Act. Specifically, they found that Nevada does not provide children with behavioral health disorders with adequate community-based services. So under the Americans with Disabilities Act, specifically the Olmstead case, this is something states have to invest in from a public program perspective. Currently, Nevada, because of the limited coverage we have in Medicaid, relies primarily on segregated institutional settings like hospitals and residential treatment facilities to serve children with behavioral health disabilities. Right now, we are still in confidential negotiations with the DOJ on the settlement agreement. But we're already moving forward on some of these efforts just because the need is now. And we also have the funding from last session, which we'll talk about that in a minute to make sure everyone is aware of what we're using to fund these efforts. And like I mentioned, we are hopeful that these efforts, along with others to come, will help us be in compliance over time with the Americans with Disabilities Act for this population. So real quick, we looked at some data on children in Medicaid who we think fall under the serious emotional disorder category or designation. And we found that about 1 in 6 of the 67,000 children in Medicaid have a serious emotional disorder designation. And out of that population, we found that 6% have SED and possibly a substance use disorder, and then 6% of the SED population have a developmental disability. And the rest, most of the population is primarily primarily children who we would consider having some serious emotional disorder. When we dive in and looked at the data a little more in depth, we found that the majority of children that we identified are in Clark County. That's no surprise to those of us in Nevada. The majority of our state lives in Clark County. But as you can see, rural and Washoe were close, and we're very close in amounts here with 6,000 children almost in rural and 7,000-ish in Washoe. About 1 in 12 of those children that are identified as SED are also in the state's foster care system. In general, we found that the serious emotional disorder affects female and male children around equally, roughly. And the most common reason for out-of-state care for children is residential treatment, and the cost annually for these services to the state is roughly $5.8 million, with the federal share covering the remaining costs. And I should just preface this, the most common reason for behavioral health services when it's out of state is residential treatment. About 60% of these kids being sent out of state are in the foster care system, with the majority being between the ages of 13 and 20. We showed this last time that our vision going forward, Medicaid, as well as our Department of Health and Human Services, is that Nevada children have access to the behavioral health services they need to live and thrive with their families and in their communities. Obviously, there's certain things that we have to do to reach this vision, and our values really surround that, which would be child-centered, family-focused, community-based, making sure the system is accountable, but it's also a system of care, and that the responses are all coordinated across all parties involved. This slide just outlines a slide that we used at the last interim Health and Human Services Committee with the legislature, just kind of outline what the behavioral health care continuum in a way looks like when you think of all the different categories. Obviously on the left side here are more low intensity services. And this is where we're really trying to get upstream and do screenings, assessments, and outreach to families, right? And try to get those early supports to really identify a child and intervene early. And then the other bucket here is the second little piece of the continuum, which is our outpatient and any of our community treatments. So this can be counseling, therapy in the community, medication management, all of those things that someone can get while and staying in their home. They don't have to be in a hospital or in a residential setting. But this is where we really want our families and our children and our adults, anyone in the behavioral health system, we want them to be thriving in the second bucket bubble in a way, right? So we want them to be able to be in their community and be able to thrive in that community and to get the supports they need. But sometimes we end up in the third bucket, which is our crisis response and emergency situations, where sometimes we do need some crisis services and stabilization services. And this is where sometimes people have to go into the inpatient side, which brings us to our inpatient treatment, as well as some folks need longer treatment, which may be residential services. And children and adults both can go along this continuum. You might think of schools as being that number one, right? And hopefully number two in time, if we can get more and more behavioral health services provided in our school system. But as we move along this continuum, on the right side is where we really see that high intensity. The needs are really much more high intense, but they're also more costly as well. So, not only is it has a benefit for the people in the community that we serve, it's also more cost effective for us to be operating in these first two buckets. And I showed you guys a visual last time at our last workshop of the new home and community-based services that we want to set up for children that we got approved at the last IFC, but I wanted to bring it back because we have a little bit of an updated slide. So on the left side, children who are coming into the system, all children at some point, if they come into contact, right, they go to their primary care doc, or they're at the school, or they are coming into contact with the state or the county in some form, that we've done some sort of screening and assessment. This is the goal. And we're going to have to do a lot of outreach and changes, especially around our managed care programs and our payment policies around making sure children are getting screened and assessed early for behavioral health needs and services. And that we want to make sure that all children and families, including foster care families who fall into this bucket, are able to access this next square of services, which is our home and community-based services for children. This includes the wraparound facilitation and to have a child and family team and to support the family and to work with them to make sure they're aware of all the services they have available to them under Medicaid. And that includes family, youth, and peer supports, individual and family therapy. This could be telehealth in some instances, depending on where someone might live, or if someone can get in, but making sure that that family is able to access therapy, as well as psychosocial rehab services and planned emergency and respite care, or planned and emergency respite care. And on this side here, these are some of these services we already cover, and I'll talk about those in a minute. But on the side here is the other services families may not realize that they have access to. And the only one that would be new here is that last one, the youth employment supports. And this would be for older youth and young adults that are still in the program, because this will go up to ages 21. And we hope to make sure that this benefit is available to children with serious emotional disorder or conditions that we tag as being serious emotional disorder. So they are able to get these services But also we want to try to get some of these services, a subset of these services available to kids that might be at risk. And we're still looking at what that tier might look like. But then the other population, right, is the foster care families. We want to make this available to all of our foster care families. And then the last group I would say is our children who have a dual diagnosis. It could be a child who has SUD. We want to make sure that they have substance use services and available to them, or a child who has an intellectual developmental disability, making sure that they can access these services as well as part of their service, that their benefit set that they have under Medicaid. So all of these things we have to go to CMS and get approval, and there's different federal authorities to do this under, and we're still working on which federal authority gives us that flexibility that we need to make sure that children, we can wrap the services around the children and not necessarily be stuck in a silo where, they have to pick between, for example, a waiver program versus this package of services. So we're working on that now. On the right side here, obviously, there are going to be children who still need residential and inpatient care. But when they do, we want to make sure it's quality care. And so part of what we're looking at, I mentioned this last time, and we got approval at April IFC, is to create these quality incentive payments for shorter stays and successful discharges. So this would be a bonus payment essentially on top of their regular rate for the daily rate. And so if they're one of our quality providers, they would qualify for that bonus payment. Also, we want to provide incentives and payments for centers that accept children that are younger, that are often really difficult to place, and also children who have complex needs. And then we're looking at a new step-down group home model similar to the qualified residential treatment facility, or psychiatric treatment facility, QRTPF. We're looking at some sort of group home model similar to that we can help mostly youth, right, and young adults, sort of that step down from the residential treatment center. So they have it's a shorter stay, but it's sort of a transition for them into the community. We're also looking at monitoring and tracking outcomes around children in and out of our residential treatment centers. So we have better oversight over time into the care and tracking that care for children. Hopefully this slide is a little not too busy. It was a little busy for me too today. This is what we are looking at. It's basically that continuum of care I showed you, I think it was like 2 slides ago. It's really looking at the individual services and how they fall under each of the buckets, right? And so just looking at it from that view and seeing where these services fall. The light blue are what we would consider new services, or there's going to be some rate changes or updates to those services. So some of them aren't new. I think that, like I mentioned earlier, the first 2 wraparound and peer supports are new services for youth and family peer supports specifically. There are going to be some rate increases as well for peer supports. And then, like I mentioned, we're doing a new QRTP-like model for youth and also increasing rates for residential treatment. Respite care would be new. We're also looking at reforming a little bit of that intensive targeted case management service that we provide and looking at possibly ways to change the payment around that and delivery system around that. We'll talk about some of that in a minute. Intensive in-home supports for raising the rates and making that available to a broader set of children. Inpatient hospital, we raised the rates on that as of January 1. And all of this is effective January 1, but I would just note that we have to go through federal approval, which does take time. So it may be backdating and some of those rate increases. Psychosocial rehab, we currently cover. We are going to be increasing rates and making that available to a wider population over time. And then same with individual and family therapy services, the rate increases. And we're doing a rural add-on payment. So any child that's in a rural area that is served, they get a rate increase for that service. And then down here are our current services. And we're also looking at the bottom there, 988, potentially getting Medicaid funding to support that program. And we'll talk a little bit more about these current other programs toward the end. I won't go into much detail because I think I just did on these things. And this is a little bit of a repeat from last time, just in case some folks were not on the previous call. Just a reminder, we're doing a new flat rate at $800 for all residential treatment centers, or PRTFs, as of January 1, 2024. But we're looking at, 2025. But we're looking at adding that add-on payment, like I mentioned, and also the quality payment. And those are the things too we walked through last time. I won't dive into them in detail, but just a reminder that these are the reforms that we did get approved in IFC, and we are moving those forward in the coming months. So you should be seeing public hearings and various workshops on developing some of these changes. Just a reminder, our financing mechanism, we are under Senate Bill 435 from last session. Nevada Medicaid can use up to 15% of the revenue from the private hospital tax. And this revenue can be used to pay for administrative costs for the tax program, and any remaining funds then can be used to pay for Medicaid behavioral health care services in the community. So we have at this point dedicated our first use of this revenue toward the services we just talked about and the rate increases. We did agree at the legislature that at IFC that we would monitor our spending carefully, because what we don't want to do is overspend these funds too quickly, because this is a new tax and it's new revenue. We want to make sure it's a stable revenue source for these services, because what we don't want to be in the position of is having to cut services or rates. So we are at this time not adding too much more to this bucket until we get a little more experience over the next year with the revenue and the spending. We will leverage these dollars and match them with federal Medicaid dollars. As most of you know, that's a 60-40 match. And to access these funds, like I mentioned, we did go to April IFC and we got approved. And thank you to any of you who testified. We really appreciate your support. And then we are going back very soon, I think next week, for delivery system modernization and vendor staff support. So what we wanted to bring up today is really when we think about bringing all these services online, how do we make sure that they're delivered and paid for and managed? Today, children in our foster care system and some of children that have serious behavioral health needs are covered through what we call our state's Medicaid fee-for-service system. Often the fee-for-service system can lead to fragmented care, and that's because there's really no clear lines of accountability for coordinating care, developing a provider network, or even monitoring, ensuring that services are provided with quality. By using a specialized managed care plan, and this is just one plan focused on a certain population who has certain expertise in this area, some states have been successful in filling the void and capacity at the state and local levels for managing and organizing care for children with behavioral health needs, especially children in foster care. There have been many states that have used this model. Arizona and Washington and Ohio are the ones that we are specifically looking at as model states. I would say Ohio RISE is a program that we are definitely looking closer at than the other states at this time. They've done a lot of great work with their stakeholders. Nothing's perfect, obviously, and managed care can have its struggles as well. But right now, under fee-for-service, we do not have any way of better delivering these services. Specialized managed care plans can help bolster state and local resources, so for supporting the delivery services, including care coordination and case management for children in foster care. So what do I mean by specialized managed care? So there's probably a lot of different questions around this. So if you look at this slide, I'm hoping it's a visual. What we're talking about is an integrated benefit set. So it's not just here's your behavioral health delivery system. It looks different over here. And here's your medical. And here's maybe if you have transportation. And here's how we do care management. It's all in one place. And there is one entity coordinating all of it. And it's all paid for by Medicaid. So I just want to put that it's an integrated model, which is a best practice. And so we want behavioral health and medical services for that child to be provided that family by one entity. We also want to make sure that transportation services are coordinated for children in this plan, and that families know that they can access non-emergency medical transportation. What we're finding is that a lot of families don't even know if they can access these services, especially foster care families. Intensive case management is also another piece of this that we think a managed care plan can bring to the table, as well as care management. Care management, you may think of the Magellan entity, for example. This is the bucket of services that they currently provide. So as I mentioned, what we're talking about is bigger. It is the whole system, and it's integrated for this child. On the right side here is all the things that we get that in a managed care system under regulation and the tools that we have at the state, because it's a managed care plan and not fee-for-service. We get provider network adequacy and access requirements and standards. We can get value added services, which are services that managed care plans have to pay with their profits, right? They can pay for the employment supports for children. They can pay for meals for families. They can help with housing supports. We can also do what other states have done, and especially Ohio Rise is doing, is looking at really strong collaboration agreements for ensuring children get services that need with the counties, schools, the welfare system, judges, and courts. We also, most plans offer a 24-hour family nurse support line, equality. We also would be using this plan to monitor quality and compare against other states with national metrics and provide different incentives for providers. I know a lot of folks get a little like, woo, what about rates? We can also do at least a fee schedule rate for all providers. So everyone would get paid currently what they did to do today or better. And what we want to see is that the plan is offering incentives around quality. We're also, what's nice about having a specialized plan is that any of their profits that they earn at the end of the year, we can have a percentage of that reinvested back into community services that we think help children and the system supporting children, including schools. We could also look at workforce development plans, something that we're already looking at for our mainstream managed care plan, which is 4 plans, right? Which is different than what I'm talking about here. I'm talking about one specialized program and one plan, but we can have them invest funding into workforce and other things that we as a fee-for-service program cannot do, and it would not cost us more money, and because we could do it under the reinvestment strategy. Another piece here I did not mention is in lieu of services that also are free to the state if they're cost effective. So some things like deadhead, for example, in transportation, right? When someone they're not getting paid for the time that they spend driving back or out without someone in the car with them, we can cover that as cost effective, right? There are different things that we could do that would add services that we currently can't cover without having to go to the legislature and asking for more funding, because managed care, again, gives us more flexibility and more tools to use. And also they have the resources and other staff that they can bring to the table. This does not mean that those that provide case management at the county level would stop providing. It could be a supplement to their current program, or they can choose if they want to hand it over to the plan. But either way, we see this as it could be a hybrid model or a supplement to what we currently do in terms of the case management at both DCFS as well as the county side. It's really just adding some more resources to the table. Our timeline for this, so right now we are hopefully getting ready to start after we get through ISC, really diving into our benefits and working to get those up and going. January obviously is the effective date for rate increases, but like I mentioned, some of those may need to be recycled back depending on when we get the actual federal approval and when we get our systems updated. Sometimes those can take 6 months or longer. By July 1, we would hope to have I don't know if it's possible, for the federal government CMS to approve our home and community-based service package that we just talked about. And so by then, hopefully we could get those benefits up and going and get providers enrolled. And then by January 1, we would be posting a request for proposals for one specialized managed care plan to focus has expertise in this population to help manage their care. And then by January 1, 2027 is when we anticipate, we hope, fingers crossed, we'd be able to start the new contract period for the plan. The reason it takes so long is because of procurements, right, as well as stakeholdering. So one thing that we don't want to miss out is to make sure we have the stakeholdering piece, which we'll talk about in a minute, which will take place from July all the way to January 2026. And then once we get through the stakeholder engagement, we want to have stakeholder feedback loops, which we will be talking about in the future. But for now, this is the piece around the stakeholder engagement timeline. The community partner stakeholder engagement. So we're thinking there's really at this time, but looking for feedback for other ideas. 3 different groups or venues or forums. The first one here would be the Specialties Plan Stakeholder Advisory Group. This group would be focused on delivery system and program development, as well as our contract requirements for the new plan and all the different pieces like the value added benefits I mentioned earlier and all the different flexibilities that we want to have. This group would be advising on that, as well as quality and network standards. And then the Family and Community Advisory Group would be the second one. This would be a group focused primarily on our benefit policies, our payment methodologies, some of those incentives I mentioned earlier, and how we want to use those to incentivize the right model of care, and then the quality assurance and provider requirements. And then the last one is one I think anyone obviously can come to. The last one is public workshops. We will be having plenty of these as we move forward. Every time we add a new benefit or increase a rate, we have to have a public hearing as well. But typically we have a public workshop beforehand unless we're under a crunch for time. But this would really be where we could have more discussion about the specialty plan, the benefit, provide updates, have a forum for feedback, and also just share updates on our timeline and work plan. We are going to be hiring a vendor to help us lift all of this because there are many pieces to all of this, and some of it we haven't talked about yet, like training for providers and other things. So we are definitely going to need vendor support and project management. But for the first two groups, we're looking for members, the representatives of counties, obviously our sister agencies, Division for Child and Family Services and ADSD. We're going to have some folks from the courts and judges, stakeholder community, families and children. Definitely we want to have not just representatives of families and children, but we also want to have some actual family voices at the table, providers, community organizations, and among others. And these will all of these forums will be open to public meeting law. And we're hoping to get this started no later than the winter of this year, hopefully fall, but just depends on when we can get the vendor up and going. And then definitely the latest would be spring of next year. We are going to have an application process, and we'll put it out on our listserv for the first two advisory committees. And we'll put out different types of stakeholders that we are looking for. And if you want to apply, or if you know of someone who should apply, please share it. And then hopefully we can get appointments made by our director so we can get those advisory committees up and going. But again, if you don't get on one, it doesn't mean you can't attend and provide public comment. So I just want to point that out, that they're not closed groups, that everybody can still have a voice at the table. Let me see, I think I'm close to done. Okay, so this is I just wanted to be honest about some of the areas that we know. There's obviously more than just here, but we wanted to just point out some areas that we know we still need some work on, right? And we may be able to do some work on this over the next 6 to 12 months. So please don't lose hope. Assertive community treatment model, DBPH, our sister agency for public health, has what they call the PACT program, but we are really thinking in Nevada we need to build out an actual model for these services and funding, and it's something we raised with the interim health committee when we met last time. And then school behavioral health services, we are really looking at hoping to get grant funding to help schools who may not have a billing vendor or support to help bill for services, so we can really get schools not only billing for nursing services, but hopefully over time, some of those counseling or other therapies that we can be providing in the school. We know that one area we're going to struggle is making sure we can provide these new services like the wraparound, right? So we need to figure out how are we going to get folks skilled, trained, licensed, certified to provide these services. So that's something we're working on in tandem with DCFS and DBPH. Services that meet the needs of our children, also that have IDD and SED, right? So children, no one comes with just one, everyone has their own unique issues and challenges, and we want to make sure that whatever benefits we put together can really meet the needs of every child, and they don't have to feel like they have to pick one pathway or the other to get services. And also looking at rate gaps, right, for these outpatient services. I know we gave a sneak preview at the interim health of some of the behavioral health rate gaps, and there were some that were very significant, and we were looking at ways to improve. Some came up on the call last time, like day treatment, partial hospitalization, IOP. I just want folks to know that they are definitely on our list, and we are looking at ways to address those. And hopefully, if we can't, with the funding we currently have, maybe next session, we'll see some movement on these issues. We also have gaps in primary care and the pediatric workforce, and we really need to increased capacity for screening and assessing children, and that's an area we are looking for ideas and strategies and partners in that work. We also, have the Patient Protection Commission. Maybe there's some movement that they can do there to help with this workforce. And then the rural access challenges, right? Those are real. And how do we meet the needs of families in the rural areas? Someone mentioned to me today that we can't have everything as telehealth. Families do need some real in-person time. And so how do we create a model that can be maybe a hybrid in some areas of the state? So just brainstorming, and we're also hoping that having a specialized managed care plan who can invest and help us build that network and a telehealth mobile structure for services. We're hoping that that will help some of those needs over time. Next steps, these are just immediate next steps. So we are going to June IFC to ask for additional staff and vendor support. So we do need to build up our managed care team, our behavioral health team, as well as getting staff to oversee this new fund and make sure that we're not overspending those accounts and that we're appropriately monitoring that, as well as staff for our Office of Analytics. Because they will be doing a dashboard and helping us track care delivery. We are hoping, like I mentioned, to secure the vendor contract in the fall or winter of this year. We are looking at getting those advisory committees started. So hopefully we can get that going for the announcement later this fall, winter. And then definitely we'll be having another public workshop once we get the vendor on board and we've got a little more movement on our timeline, and we'll give an update hopefully this fall or winter. But you may see public hearings and workshops just in general about some of the individual benefits as we begin to develop and get those ready for federal approval. Right, I think that's it. So I'm going to open it up for questions and stop sharing my screen so I can see you guys. Okay. How are we doing on time? Let's see. Oh, Megan, I see your hand up. Is this time your hand up for real? Oh, did you put your hand down, Megan? Sorry. Okay, did anybody have questions? Oh, I see one at the bottom. Can't see whoever's hand that is, so if you want to start chiming in, that's okay.
Hello, I'm new to the meetings. This is my first one. So it sounds like, and correct me if I'm wrong, is this strictly for kiddos who are ward of the state, or is this also for outpatient behavioral health providers as well, as far as like the new things to be put in place that can support families with wraparound services?
It's for all kids, so there's both populations. So unlike some states, we're going to roll it into one package. So we're going to do foster care kids, so all kids in the system, right? Any child in the system will get access to these services. And then any child who has a serious emotional disorder designation, could be a child, any behavioral health challenges that fall under that umbrella, they could have access to these services. And like I mentioned earlier, we're trying to come up with a definition. For example, a child who maybe had a mobile crisis visit, right? Or maybe had some interaction with JJ and the juvenile justice system. And some of those indicators that might put a child at risk, we want to have some of these services available for those children as well. So it could include outpatient behavioral health. And that's the goal, is to get more outpatient behavioral health and less residential treatment.
Thank you.
Mm-hmm. A good question. Karen, were you going to jump in? I thought you were. Oh, Carly.
Hi. And in one of the slides, it mentioned that these services would be available to any child with behavioral care needs. How is that determined? Do they have to have the SED designation?
Well, that's what I was just saying. Like the SED designation is something we often providers are not right now. We're not necessarily tracking as well as we should. So we need to start that. But I think there's a list of conditions that we can define under that with community feedback, but also any child may be at risk of SED. So we don't want to, we want to get kids as early as we can, right? So we need some help in defining that. Other states have done that. I think Alaska, they have a little bit of a different model, but they have an in-home family behavioral health service program, and some of their early at-risk services are for kids who maybe had interaction with juvenile justice, right? Or had a mobile crisis visit. And so they get some of these wraparound services earlier than having to wait for a designation. So we're looking at both models.
Tracy, there's a question in the chat that says,
oh, thank you.
Is there a reason that the consortia wouldn't be used instead of another advisory committee?
Who's the
And that was from-
consortia? What consortia?
That was from Shar Frost. Perhaps. They
Shar,
could
which,
unmute.
we have so many committees. Which one are you talking about? Sorry, maybe you can put it in the chat. I can't hear anyone. Children's mental health. I mean, we can definitely report back to that, but I don't want it just to be, thank you, Cody. Do you want to chime in?
I was just, perhaps I can help. There
Thanks,
are
Cody.
regional children's mental health consortia, somewhat similar to the children's or to the regional policy boards. And I think that's what Shar might be
Got it.
referring to.
Yeah, if they're regional, I think that would be great. I think we want to open it up to more than the people that currently have voices at the table. So maybe we could definitely use some of those representatives on this. So there is some of that regional support. Cody, I don't know if that works for you, if they're under your division. Okay. But no, thank you, Shar. That's a good idea. Is there a reason? Okay, how is there, Stephanie, so Dr. Woodard, how is this work informed or coordinated with the Family First work through DCFS? Dr. Woodard, do you want to explain kind of what you're talking about there?
Yeah, sorry, it took me a second to come off of mute. I'm actually going to put in the chat what is at least available online currently for the Family First Services Prevention Act, but every state is required to have a prevention plan in place with the idea of identifying children and families that are at risk for involvement with the child welfare system. And so there is a Title IV funding that's also attached to these plans, and just wanted to see if there is work being done to help to align these initiatives so that we can maximize the federal funding and federal match for these programs, regardless of whether a child is in Medicaid or not.
Yeah, so my piece is mostly focused on the Medicaid piece because that is where the DOJ side of it is, but definitely we'll reach out to DCFS and make sure that what the work they're doing is not duplicative. But thank you for flagging that.
Woodard, this is Marla. If you could include your email in the chat, then we can get back with you.
Thanks, Marla.
Thank you.
Any other questions? Sorry. Stephanie, do you have your hand still up or sorry if I'm seeing an old hand up.
No, I do, but I think other people had their hand up first, so I'll wait.
Okay.
And time, feel free to circle
Gotcha.
back with me.
Okay. Kay Graham.
Sorry, that was an accident. I thought I was down.
No worries.
Sorry.
No worries. All right, Dr. Woodard, I think it's still you.
Stacy, this is Monica.
Oh,
Karen
sorry, Monica, go ahead.
That's okay. Karen Teacher, I'm sorry, has had her
Yes.
hand up as well.
Sorry, I'm having a hard time seeing everyone. Thanks, Karen. Hey, Monica.
Hi. I want to go back to the who is eligible. I understand your answer, but I believe it's yet to be determined. So are there going to be public workshops about?
Yes.
Okay. So
It's also a matter of the authority the feds give us. So we need to really get the vendor that we want to do this on board and to help us define. I mean, right now for sure it's SED and foster care, but how we define SED, for example, and how we define the at-risk population that we want to add, I think are the two that need refining. So when we come back with the public workshop, we would definitely give you guys those definition and get feedback. But some of it may be stuff that CMS says no to, because what I don't want to see us do is have to go down the 1115 waiver route, because if we do that, we will be waiting for CMS for 5 years. So I'm struggling with what authorities I can use that I can get done quickly. I hope that makes sense.
I appreciate that. I just want to put it on your radar that about 25 years ago, I'm saying this because I don't want it to happen again. Families could only access the behavioral health care their children needed by relinquishing their rights and getting the child into foster care. I
Yeah.
just want to make sure that that the definition
That's
of
the goal
SCD
of this, yeah.
does not drive families to have to relinquish their children because foster care kids are going to get it.
No. No, that's the goal of this. Right now, you could argue our system is built that way. You can't access any intensive in-home supports unless you're specialized foster care. Do you know what I mean? So like right now, our system isn't working well in that way. So I think what we're trying to do here is make all the services that are available for foster care kids available to families who have children with behavioral health needs, which falls under that definition of Teresa, maybe help me on what you guys like different disorders that fall under that. I know children don't necessarily get diagnosed with serious mental illness, but it's that definition of serious emotional disorder designation that does not include being in the child welfare system, if that's helpful. But I appreciate that concern because we don't want that at all. Dr. Woodard, did you want to go?
Sure, thank you. So first, let me just say I want to applaud all of the efforts that Medicaid and DHHS is undergoing to think about a coordinated system to support kiddos, not only while they're in child serving systems, but before they're in child serving systems. This, I think, evidences a ton of work that's happening just across the department. So wanted to say that because I know lots of people on these calls have been part of conversations ongoing for several years, and it's great to see that there's continued momentum and interest in building out a system that really is right-sized for families and children. A couple of things I did add into the chat, some SAMHSA estimates for prevalence for children with SED in Nevada. Granted, this was 2022, so Cody or someone in DPBH may have estimated updated estimates from 23, but this is what's currently available in public and online. The reason that I point you here is because we know that in order for a child to get the SED designation and to meet those clinical criteria, you need providers on the front end that are capable of screening and assessing and making those clinical determinations. And just want to make sure that as you are moving forward, you have information available related to the prevalence estimates, because while I understand that pulling data from the Medicaid system can be helpful to guide how many kiddos in Medicaid currently meet that SED designation, to have those prevalence estimates can maybe help understand the potential size of that population within Medicaid. The other thing I wanted to do is just punctuate the idea of needing training and technical assistance for providers. There was a pretty extensive workforce engagement a couple of years ago where we talked about the need for some of these newer services that haven't really been rolled out, or at least rolled out to scale within the community behavioral health system, including respite, intensive family in-home, as well as high fidelity wraparound. And one of the things that became abundantly clear is that there will be a need to engage the provider community in training and technical assistance, and then quality oversight to ensure that those services are being rendered in a way that's in accordance with what the policy sets forth. So just knowing that that workforce capacity is a real challenge and will need some additional resources for it, so that we can make sure that not only are the services reimbursable, but that we have providers in the community that really know and understand what the service is and how to provide it in a way that is that has fidelity to what you're looking for.
Thank you, Dr. Woodard. Yeah, no, I appreciate that. It's something we are aware of and definitely need to build out. And that's part of the plan. It's just right now we are just giving you, we just need to get if we don't get started on the benefits now, by the time we train I'm hopeful by the time we get the authority, then it gives us plenty of time to train the providers. So I'll be honest, it's going to probably take over a year to get the authorities we need. So it's one of the reasons we're having this conversation. Typically, we obviously, right, want to train the providers and do all of that, but it takes so long for us to get CMS and federal authorities that we are starting this now. So, but thank you. Carly, did you have another question?
Yeah, so you mentioned limited funding. Will there be a certain number of slots available for children to receive these services like there are under some other
No.
waivers? Or it'll be open to anybody
You
that needs them?
cannot, in my opinion, violates the ADA. I mean, we have to be mindful of wait lists. Like I feel that would not be viable under the ADA. We cannot deny. So I think we have to open that up for children with behavioral health disabilities. So no waiver wait list. It's not a 1915C waiver. That's why we're building a benefit package and that part of the mainstream Medicaid program and integrated. Eagle Quest. I don't know who, I just see the name on there. Did you guys have a question?
Hey, Stacy, this is Dave Doyle with Eagle Quest as well as with FFTA. Appreciate you and your team hosting this meeting and always fielding all the questions. It's kind of a nice feel to do this in advance, and we continue to appreciate your efforts. I just want to, on behalf of the specialized foster care providers, we'd love to have a position on and wanted to find out if there's a formal mechanism to get on that advisory board, advisory council, to help, and how to implement as well as to identify potential unanticipated consequences, because we don't want, none of us want that. Is there going to be a formalized process to express interest on that board / advisory council? Thank you.
Yes, there will be. We need to figure out all those out. I mean, part of, getting that feedback on the consortia was a great one, so we can make sure there's space and make sure we're coordinating across all these other committees. But we definitely want to make sure we have all the voices we need at the table. And so part of the people sitting at those tables will be putting out an application process. So you just would submit a letter of interest, in your resume, or we'll see what all the pieces we need. But it wouldn't be time consuming to apply, and then we'll consider who wants to be on it. And we'll also have different types of positions that we want to fill. We just need to have that conversation with our sister agencies and our director's office. But that will be coming hopefully this fall or winter.
Thank you.
I see another hand and I'm having a hard time figuring out. Oh, Luke.
Hi, yes, thank you. Can you hear me okay? Thumbs up?
Yes, yep.
Okay, thank you. Headphones tricked me out last time, so this question comes from the FASD lens. And for those of you who are familiar with that disability, you know that oftentimes they will collect a laundry list of other diagnoses before finally getting across somebody who can actually identify. And so this SED sort of seems to me like that would be the first level catch. So my time in the school district, oftentimes I would follow the breadcrumb trail of different diagnoses that just didn't really quite fit, or things weren't really working. So we just keep asking those questions. And so the definition of SED, it kind of separates it from a developmental disability. And so what would this look like if a child's having issues, maybe gets picked up under SED, a little bit more digging. Then we go ADHD, autism, and then right around high school, they get the FASD diagnosis, right? And that's like this really drawn out process. I'm kind of thinking about like more universal screening, universal access to basic services first, and then we can kind of specify the diagnoses later. But I think the theme is, why are we stopping people from accessing the help they need? Because they don't have the right name tag. Right?
Exactly.
And it's our problem, our system's broken because we don't have consensus on the diagnosis. We don't have screening. The same path that autism diagnoses followed, where now it's more mainstream and a pediatrician can give you a diagnosis. Maybe FASD follows similar, and SED, mental illness, probably is in that tree somewhere. I know other states are doing packaged waiver programs, and I know you said that's a really, really long process. So I like looking at this and just reducing those barriers, to start asking those harder questions a little earlier, so we can avoid, those secondary disabilities that everyone is looking at. But yeah, thank you for your time, and I'm glad so many heads are thinking about this problem.
No, Luke, I really appreciate you sharing that, because it's exactly what we're trying to figure out. How do we best do? How do we define it? So, children are getting in the right door and getting the services they need. So if a child has FASD, but they also have behavioral health challenges, right? And like maybe the IDD side is not enough or it's not available to them. Maybe it is the behavioral health side that we can provide these services, but either way, the child should not have to choose between one or the other, that they can get the services they need to meet their needs. So I think that is, like you said, the waivers that a lot of states are looking at is a way to do that, but I'm worried if we go down that waiver route. So I'm trying to figure out a creative strategy to use like a 1915I, for example. It's a different authority, which might be faster. But we definitely, North Carolina has a tiered benefit, and they have a benefit for IDD, SED, right? For children that kind of are in that middle zone. You know, we're gonna look at that, but definitely before we solidify anything, we'll bring it back to this group and publicly get feedback on it. And obviously you guys can send in written feedback too. Because we want to get it right, and nothing may be right away, but we can amend, right? But the key will be, will the feds allow us, how quickly they will allow us to get to children? Because often they do want a diagnosis or something. So we have to think together about what that looks like. So I appreciate you bringing that up, because I think that's exactly the challenges that our children are facing right now, especially in school. So thank you. Let's see, I think, Monica, do we have more questions? Or are we good?
Dr. Woodard just made a comment in the chat that definitely need a better way to train, track, and ensure SED
Yep.
determinations are conflict-free.
Yep.
And
Definitely.
then somebody asked if this was the definition you're speaking to. And
that is the definition we currently use. That doesn't mean it has to be the definition that we use. So I just want to say, if folks have already feedback on what we currently use, give us you can send it to us by email. But just like we are creating this now, SED is just something that we are able to hang our hat on and say that is one way to identify children with behavioral health disorders. If there is something else that you guys think that should be added or changed, that we can have a fair diagnosis or some sort of designation from a physician or licensed provider, that gives us what we need with CMS. So I just want to say that this is our starting point and not necessarily like, don't nobody panic, right? Like, this is a starting point for us to get feedback. Magdalena?
Yes, hi. So this is a big transformation for sure. And I'm thinking of the families who have the parents work in casinos and have culinary insurance. And the youth has an SED, you know, it has mental health issues, a lot of our families. So how would this work? Would they be able to qualify? Would that be easier for them to qualify now?
You have to be Medicaid eligible. So so I'm sorry.
This is what
I can't. If you
Yeah.
need to deal with that, you have to talk to culinary and the union. So I can't fix that issue for you. But Medicaid, if you're Medicaid eligible and your child has SED, which most of the time, a lot of, even with our adult population, a lot of the population is on Medicaid, but I don't know. I think it would have to be an issue you work out with the culinary insurance.
It's a culinary issue then, not Medicaid.
I'm sorry. Yeah, I'm sorry. I wish we could help. Maybe we could think about a buy-in option in the future, but let's get this done first, and then we'll talk, and then we'll think about other solutions. But I'm sorry, I don't have anything on that yet. Karen, you have your hand up.
So I know you probably can't answer this, but
you can still ask it, Karen.
The DOJ settlement agreement covers more than just Medicaid, right? Because typically the family that Magdalena referenced, there's a lot of families like that, they are considered underinsured, or they use up all of their private insurance.
Yes. So the DOJ does not cover private market because the ADA applies to the public. So the insurance here is Medicaid.
Interesting. So besides a Medicaid transformation, there is no other system transformation?
I mean, there's system, but you know, if Medicaid adds all these services, usually other payers come along. I mean, we usually are one of the bigger payers, but at the end of the day, the ADA applies to, the public side. We can't force the private market to take children, to serve children, to add services, to unless you get a private mandate, but the state's not required to force providers to take children either. Like, we can't.
So we've been kind of operating that DCFS would take the uninsured or underinsured.
Yeah, that's different. Yes, those are taken under the state's authority, so we have to ensure that they're taken care of. So yeah, there will be, but I can't cover them under this program.
Okay.
But there would be state funding. Those would still have to be state funded. But private insurance is not under the ADA.
Got it. Thank you.
It's a different type of ADA. It'd be like parity law or something like that'd be a different part of the strategy if you're going to go that direction. Won't the Medicaid get contracts be private companies? Yeah, but they're still contract. So I just saw the Trey's message. Yes, but they're contracting with us and taking our money, so they have to follow our rules. So I hope that answers your question. Any other questions? Let's see.
Looks like Julia Ratty has.
Oh, hey, Julia.
Hey, Stacy, it's Julia. So it's just, I think the other insurers part is interesting. So I guess a question, because I totally agree that often when Medicaid puts together a good mix of programs, other insurers will follow along. And isn't often part of that because you're going to be able to demonstrate some cost shifting or cost savings, right? So I think from a strategy standpoint, super important that whatever we can do to set baseline data from now, and then understand that if we're catching kids, if we really do get upstream and we catch kids before they deteriorate and we get them in a less expensive setting than acute settings because we're doing a better job of providing wraparound care, if we can capture that data and then share that data with Culinary Union, not to just call out the Culinary Union, but they are a significant player, certainly, and others, that is the win-win where they then come along and do similar things because we can demonstrate that it's not only better for people, but also better for pocketbooks. So whatever data collection we can, that's my point, whatever data collection we can do up front to show our current state and then our secondary state, both from a healthcare outcomes, but also from a, did we save some money along the way? That would be great.
Yeah, I like that. That's exactly right. And Julia, we could do like an ROI, return on investment analysis. So we can show, I mean, we assume it's cost effective. There's enough studies, but if we actually show it right for this population, which we can, we'll be able to show compared to the fee for service payments we pay today versus the outcomes for these kids. Because residential treatment is very expensive, as we all know, comparatively speaking. Yeah. Thank you.
So then some advocates can go talk to the Culinary Union and show them the data.
Yeah, or go to DOI or go to the state and ask for mandates, right? I would love it if more people cover stuff so we don't, it's not all in Medicaid's bag, but Yeah,
unfortunately, most of our mandates at the state, we can't do ERISA plans because they fall under
exactly,
federal
that's
law.
the majority.
So even we couldn't, even if we could, we couldn't generally tell the Culinary Union what to do because they're ERISA.
Exactly. So. The ERISA plans make up the majority of our market. Any other questions, thoughts, feedback, or anything you guys want us to think about? Like, especially, the SED definition, if you guys think there's a state that's doing it better or you have thoughts about that, feel free to email that. I don't know. Monica, do you mind putting the community stakeholder email address in there? We'll track some of that. So if you guys have thoughts and you don't want to talk on this and you just want to send us information too, that's helpful. You guys are quieter this time. Uh-oh. Okay.
Stacy,
sure. Yeah.
It's Karen.
Yeah, go ahead, Karen.
So I said this last time. I'm going to say it again so it stays on your radar.
Yes.
But I know that you're probably working out the details, but the psychosocial rehab, there's got to be some clarity around that service provision.
You mean to prevent fraud?
Yeah, and inappropriate activity.
Yeah, okay. Yeah, I know. No, definitely. I mean, I think there are things that we can do better on the back end, right? To monitor and educate providers that can help us to avoid some sort of situation where we're all like, everything is bad, shut it down. Like that's never a good reaction. And so I think there are things that we need to do around provider education. And then also just, any feedback or ideas you have on what might be helpful around that, we're open to that as well. But definitely we understand that that's a need and appreciate the concern. Oh, I think maybe Karen, you got 2 more hands up for that. Shar, did you have, or is it Char or Shar? I'm saying Shar. I don't know.
I respond to either.
Either? Okay. Which one do you prefer though?
It doesn't matter,
It doesn't
honestly.
matter. Okay, cool.
Yeah, I used to live in Mexico, so I've been called both. So
Oh,
my question is, one of the historic problems that we've seen around children's mental health is the siloing of the divisions, right? And sometimes even the siloing of different parts of the division within a division. So I guess my question is, are we going to see less of that? Are DCFS and DHCFP in the same sandbox? And what is going to be their role in all of this?
yeah. So I know Cody and Marla are on. I don't know if Dina was able to make it. I mean, I'll just say this, that we all talk regularly, but we're all busy doing what we need to do. So it's not like every day we're getting together, comparing every notes, but we're all talking. I will tell you that we see this as really writing the system in terms of who is the payer versus, right, like each of our roles. And so us as the payer will drive the policy as well as the requirements around this. Cody's role, right, would be any licensing, and we would be coordinating to make sure providers have the appropriate licensing structure. One in particular that comes to mind is the respite care, right? What is that going to look like, and how do we work with her team? We're going to need her team, and I know she'll work with us, and we have good relationships with that team to do that. Dina's team we already met with them, last week to talk about the IDD, SED kids and how we're going to do that. So as we're building that out, we'll be working with them. DCFS, they are a provider in the system, and they also provide case management to kids with in the foster care system under the state custody. And so we would definitely be working closely with them, especially if we develop a specialized managed care plan to ensure that whatever resources we're bringing in would be supplementing and helping them ensure that these kids get services. We see them as a provider. Most of, except for DBPH, our licensure and regulator, for providers, we see like ADSD and DCFS as our provider in the system, if that makes sense. And so we want to make sure that they're part of the network, that they're part of the program, and that we're coordinated in that. I hope that helps answer your question, but we all are on the same page, and that's probably why they're all on this call. I don't know, Cody or Marla, if you would jump in and add anything, or you just want to say that at least that you're aware of the things going on and that we work together on these issues. Is Cody not still on? Oh, darn. She would have jumped in. Well, now, is Marla, are you still on? I don't know. They're probably all gone. I don't see them anymore. But no, we do meet on these issues. So, and we've all been working on the DOJ in some form or fashion together. All right. Karen, did you have your hand up? Saw it go up. Or Britt, sorry, Britt.
It's okay. Sorry, I was having a hard time unmuting myself. I was just curious about mobile crisis, and would children on Medicaid have that only sorry, would only children on Medicaid have access to mobile crisis, or would that be for every
Mobile crisis is designed for everyone. We would pay for Medicaid for kids that use those services, like in my mind, from my perspective, it's a provider of a service that we cover. All kids have access to it. It's just that for DBPH runs it, right? And so does different parts of the, 988 is one that comes to mind, but we would be paying for the service as well as we're going to be paying for the administrative costs of the program. But all kids should have access. Any other questions? Going once. Okay. You guys were easy this time. I'm kidding. No, you were not easy, but thank you for all the hard questions. Appreciate it. Again, if you have thoughts and want to send them in, please do. And we will do this again in a couple months, and hopefully we'll have maybe a vendor on board. We'll see how quickly that we can move that. That will help get some balls moving for us, because I think we're trying to move a lot all at the same time. But thank you for your time today. Very much appreciate it, and look forward to next time and to keep talking. Thank you.